Hello everyone. So here we're going to discuss the first case of the 4 cases series where we are going to talk about patients who are deteriorating over time and becoming critically ill. We are going to use the knowledge that we gather during our lectures, so the physiology, the ranged physiology, and how to apply our knowledge at the clinical in the clinical setting at the bedside. So let's start with the first case here. This is a 76 years of age man with a background of hypertension for which he takes some hypertensive drugs. Left hemicolectomy for colorectal cancer in 2016 and renal stones. So that's what we know about the patient. Patient presented to ED, brought in by his wife due to worsening right-sided abdominal pain that began earlier in the day, now worsening and radiating to his flank. He has had general malaise for the past 2 days and reported sweating and shivering at home prior to admission to ED. So, what is your differential diagnosis? Again, just think about the presentation. That's all you have there. Worsening right-sided abdominal pain over a couple of days, radiating to the flank, sweating and shivering. Okay, so when we discuss differential diagnosis, especially for your exams, it is important to have a broad idea of what could be going on here. Usually during an exam, the examiner doesn't really want to hear the only answer or the only correct answer, although it's obviously preferable that you identify the correct answer. But usually the examiners would like to listen and hear your reasoning and your critical thinking. So here, if you think about the patient's presentation and patient's history or background, you can start to analyze it from taking a step back and trying to understand or try to imagine what's going on there. So it's an abdominal pain, so that's an acute abdomen. So one easy, simple way to think about it is, what is in the abdomen, which organs are present in the abdomen, and you start taking it from there. So the main thing that comes to mind is the bowels, obviously. So the patient has had a previous colorectal cancer removed in 2016. So perhaps there could be, another cancer going on there, or maybe, because he had surgery recently, he might have some adhesion, and the adhesion can cause, bowel obstruction. So the patient might be having a bowel obstruction there. Could there be a perforation as well? Perhaps, yeah. So bowel obstruction, maybe bowel perforation, who knows? Diverticulitis could be, although it's the right side here. Maybe appendix kind of comes to mind, appendicitis, simpler things. Could be also some other organs apart from the bowels. Could be pancreas. Sometimes pancreas, although is a organ that sits in the center and usually the pain radiates to the back, sometimes can radiate to the upper right flank. So yeah, that could be one of the possible reasons. Other things that come to mind, perhaps maybe the patient has a history of kidney stones, so that could be another reason for right-sided pain, abdominal pain, that is combined with general malaise. And also another often forgotten reason for abdominal pain is aortic aneurysm. The patient has a history of hypertension, and sometimes people with hypertension are presenting with vascular issues, among which we can find an abdominal aneurysm. So that could be another reason for abdominal pain. And also, one thing that you have to notice here, the patient is sweating and shivering. So that really narrows down the possible options there. So, sweating and shivering, you really usually see them when the patient is either having a lot of pain, or the patient is having an infection going on, or is bleeding. That's something that people also tend to forget. Patients who bleed acutely they present with some cold sweat and shivering. Anyway, so those are obviously something that you might want to discuss at your exam. You just have a broad idea, a broad kind of a overview of what could be going on there. So from here, so basically what we want to hear from you during an exam is, do you identify the main causes of an acute abdomen, basically. Focusing on the actual presentation of the patient, which is, right-sided abdominal pain, radiating to the flank with sweating and shivering, with that medical history. So from here, what investigations are you going to perform and why? So, again, you know very little about the patient, so really what you want to do at this stage is start from the basics, and the basics are lab tests. So you take your blood samples and you want to identify the full blood count because you're interested really in the white blood cells here, and also obviously you're interested with the hemoglobin and the red blood cells in case the patient was bleeding, although hemoglobin doesn't really drop immediately during an acute bleeding. It drops after initial resuscitation, and we'll discuss that later in another lecture. So you take your full blood count, white blood cells here, you're interested. You take your UNEs, you want to have a look at the electrolytes and creatinine maybe, because the patient might have a kidney problem going on there with the stones. Urinary cultures, and also blood cultures, because the patient is shivering and sweating, so you want to exclude any infections, so you take cultures from the blood and from the urines, because you want to identify the causative organism, and you're doing a septic screen basically. And then you take a urine dipstick and for microscopy. So the urine dipstick is a quick test that you can perform at the bedside. And let's just have a look here quickly, and just a quick focus on the urine dipstick, because it's a quick tool that you can use at a bedside. And I think you should familiarize yourselves with the actual dipsticks and how to interpret it. So usually the urine dipstick is taken with a midstream urine, which is not achievable in someone who's acutely ill. You can't really ask someone to urinate in different pots while he's acutely ill. So you usually take it from the urinary catheter bag. This specimen of urine is collected into a specimen pot, which is yellow in the hospital. Then you dip your urinalysis stick for like 5 seconds, and you wait like a minute to read, and the leukocytes, the white blood cells must be read at the 2 minutes mark. And then you send for culture and sensitivity if you have some suspicions, or if you're doing a sepsis screen. So how to interpret the dipstick? You have one thing I would suggest you really is actually to take one from the wards and just ask the nurses to give you a urine pot with a dipstick analysis, and you just have a look and read it, and you just familiarize yourself with these values. So the specific gravity monitors the ability of the kidneys to dilute or concentrate urine. You can have a look at the pH, which is normally between 5 and 6. And if it's above that, usually you're having a urea splitting organism like a Proteus. You can see if you can find white blood cells, which indicates a urinary tract infection or a vaginal discharge. You can see if there is blood there. You can see if there are nitrates, which is nitrates are usually present when bacteria are present. You can see the presence of proteins. Proteins in the dipstick can have many causes, and they could be renal or non-renal, as you can read from here. Now, in practice, when you are suspecting a urinary tract infection and you wanna have a quick assessment, the things you look at are the proteins, nitrates, and leukocytes. So if you find nitrates, leukocytes, and proteins, yes, most likely you're having a bacterial infection going on, a urinary tract infection. and from there you take and you send to the labs for a culture. So imaging, you took your labs, you took your urine, dipstick, and then you want to have some imaging because you have a patient presenting with an acute abdomen. You don't really know what's going on. You have identified many possible reasons for that, so you want to have a look, and the way to have a look is to actually perform some imaging here. So CT of the abdomen here, it's showing stone exactly at the pelvic-ureteric junction that is causing hydronephrosis. So that's quite a significant finding on the CT abdomen here. There is a stone that it's causing hydronephrosis of the kidney. Okay. The CT in this case does not show any bowel abnormality, so there's no bowel obstruction, there's no bowel perforation, there's no aortic aneurysm. So really, it's the CT scan is really narrowing down all the causes to the actual cause here. So then you have your ultrasound of the kidneys, because again we have identified that the problem is a stone there, and you observe the kidneys with the ultrasound here. So you can see the stones, and you can also see the fact that the kidney in this case is enlarged, and there is decreased echogenicity, so the boundaries are a bit less clear, and there is loss of corticomedullary differentiation. So this finding is typical of pyelonephritis. Okay, so there you go. So from here, you had a quick assessment of the patient. You really had a quick physical examination, history taking, basic labs, urines, and imaging. And from here, you can actually start to formulate your diagnosis. So your diagnosis is pyelonephritis in this case. So what is your management plan? Okay, from here, now that you have uncovered the underlying cause, you're gonna have to treat it, because the problem does not resolve unless you treat the underlying issue. So in your management plan, when you have such a clear cause of disease or illness, then yes, you have to treat the underlying main problem, and also at the same time treat the associated symptoms. So the patient is feeling very sick. We know that there is a stone there, so perhaps we want to involve the urologists or the nephrologists. We just want to talk to them and see what they can offer in terms of possible interventions there, and maybe they can help us with the management as well. So yes, we call the experts and we start to treat the problem. So if the problem is pyelonephritis, as we think, there might be an infection going on there, because we saw that during the dipstick, we probably realized that the patient was having a urinary tract infection. So there's a stone, there is pyelonephritis, and there is bacteria in the dipstick. So yes, you want to start to treat with antibiotics there. So that's how you start to treat the underlying problem. You involve the experts, you see if this stone can be removed, and at the same time you start to treat with antibiotics. And then you treat the associated symptoms. Associated symptoms in this case are pain, so you start to treat with painkillers. And then you start to think about location. Where does the patient have to go? Is the patient going to a ward? Is the patient going to theater? Is the patient going to a high dependency unit or an intensive care unit? So that's your initial assessment of someone who's presenting with a clear cause of acute abdomen. So antibiotics, there is a lot of help in for how to choose which antibiotic to choose for which complicated condition. So there is an app here in Sligo. We have an app which is very similar, if not the same app that it's used in the Galway University Hospital. And it really helps a lot with the standardization of management, because it really lays out all the possible causes of infection, and then you can just follow it, and it is really clear, and it really helps you to give the right antibiotic in the right setting. So in this case, you open the app and you look at you start looking at the pyelonephritis, or complicated UTI page. And the first line antibiotics you see here is coamoxiclav. Okay, so amoxicillin and clavulanic acid. 1.2 grams every 8 hours plus gentamicin IV 1 dose as per calculator. Okay, so if there is penicillin allergy, then the choice is for ceftriaxone IV 2 grams every 24 hours and add gentamicin if hemodynamically unstable. If so there was a penicillin allergy that was mild. If there's a severe reaction to penicillin, then instead of ceftriaxone, you're gonna give ciprofloxacin IV 400 milligrams or PO 500 every 12 hours. Again, add gentamicin if hemodynamically unstable. So anyway, for each clinical condition that you have, you can find the appropriate antimicrobial management. So this app really helps you a lot, and I would suggest you to download it if you don't have it and use it all the time. So anyway, you started your treatment with antibiotics. You started to treat the underlying cause. But then the patient in the evening, he's confused and upset. You know, he's attempting to get out of the bed and go home. He's unsure where he is, distressed, mumbling and pale. He has pulled off his nasal cannula and pulled out his IV access. So patient looks very confused, agitated. These are the vitals. Heart rate is 118. Blood pressure is 89/64. Oxygen saturation is 90%. Rest rate is 28 breaths per minute. And temperature is 38.4 degrees Celsius. So what is going on here? What is happening? And how would you manage? Okay. You can pause the video for a couple of minutes here, and with what we learned together in the lecture about sepsis and in the lecture about circulatory shock and the lecture about the early warning score, please try to stop the video here and try to understand what's going on here, what are your concerns, and what would you do. So for those of you who paused and came up with ideas, congratulations. For those of you who just want to enjoy the lecture, what's going on here, you have to start by understanding the big picture. Okay, because in this condition the patient is clearly deteriorating quite rapidly here. All the vitals are off. But it is hard to make a clear diagnosis if we don't have the big picture in mind. Okay, so the big picture here is that the patient is, we know that the patient is having a pyelonephritis, and the patient now, it appears to be confused and agitated at the bedside, in his bed. So the vitals are going off here. So you want to observe all the systems, and you want to observe the systems using the early warning score chart, which is conveniently present in every single chart at the bedside. So you just open the patient's chart, you look at the early warning score chart, and you assess the variables. So the patient rest rate was around 28. So as you can see here is above 25, and we give it a score of 3. The saturation is below 91, it's 89 actually, so you give it a score of 3. And the patient was actually on nasal cannula. As you can see here, he's pulling off his nasal cannula. Oh, sorry, the saturation is 90% here. So anyway, it's below 91, so it's a 3. And the patient is on oxygen, so it's again another 3. Then you look at the blood pressure. The blood pressure is 89 systolic, and you give it a 3. And the heart rate was 118, so it's a 2. Then you go to the AVPU score, and he's alert, although very confused and agitated, but he's alert. So it's a 0, and the temperature is 38.4, so that's a 2. So if you sum up everything here, is 3 plus 3 plus 3 plus 3 plus 2 plus 0 plus 2 is 16. So the patient has 16 of early warning score. It's a disaster. So from the chart here, if the patient is having 7 or more of score, then you should involve everyone. The nurse should be the nurse in charge should be involved. You should be involved, obviously, and the patient's team should be involved. So the registrar, the on-call registrar, and the consultant as well. The consultant must be aware of the patient in this condition. The senior doctor, so the registrar should senior registrar should review immediately. There has to be a continuous patient monitoring at the bedside, and there has to be a clear discussion with the intensive care crew. So an emergency response system must be activated at this stage. So from here you can see that the patient is quite critical. The big picture is that the patient is clearly rapidly deteriorating in front of your eyes. And another thing to consider is that the patient is not going to tell you that he's in septic shock. You have to make the diagnosis here. And to make the diagnosis, we know that the patient is having a low blood pressure. But again, to assess hypoperfusion, as we discussed in the previous lectures, you want to observe the three clinical windows of hypoperfusions. And those are the brain, the kidneys, and the skin. So a patient who is hypoperfused is usually agitated and confused. It's not in coma, but is agitated and confused, typical of patient in shock. Is having a low urine output and is having a mottled, pale, and clammy skin. So from here you might want to take a lactate measurement, and if the lactate measurement is above 2, as we discussed previously, then you are in the presence of a circulatory shock. So that's the patient's blood gas here. The pH is 7.3, CO2 is 6.2, PO2 is 9.5, bicarbs 19, and lactate 2.2. So the patient here is having a mixed metabolic and respiratory acidosis. Metabolic because, bicarbonates are below the normal range. So there's a metabolic acidosis there, and the reason for that is most likely the hypoperfusion. As you can see, the lactate is above 2. So patient is having a metabolic acidosis combined to a respiratory acidosis there. So probably the patient is also tired and he's not breathing very well. So the patient is having a mixed respiratory and metabolic acidosis there, and his oxygenation is poor. So it's below the normal range. It's not incredibly bad, but it's not obviously normal here. So the patient is having a mixed metabolic and respiratory acidosis combined with hypoventilation and decreased oxygenation. So that's a type 2 respiratory failure combined to a septic shock. Management. That's the management of the septic shock. All right, as you remember from the latest lecture on septic shock, we discussed that you're gonna have to take 3 from the patient. You're gonna have to take blood cultures, a lactate measurement, and urine output, and you have to give 3 to the patient. So you have to give oxygen, antibiotics, and fluids plus minus vasopressors. So let's briefly discuss this again from the septic shock lecture. You take blood cultures to try to identify the bacteria or the microorganism in the bloodstream while the patient is having a septic shock. So you do that before giving the antibiotics. Then you take the lactate measurement because you want to monitor the perfusion of organs, and the urine output because that's another way to monitor hypoperfusion of the kidneys. And then you give antibiotics, you give oxygen at the same time, and you give fluid and vasopressors. Fluids and vasopressors can be given at the same time, and fluids typically it's recommended to give at least 30 milliliters per kilogram of crystalloids, and that's to counterbalance the effect of the septic shock and the hypovolemia overall. So all this management should be carried within the first hour. Okay, so as we said, it's important in sepsis and septic shock to treat early and aggressively. You want to treat within the first hour because for each hour of delay, there is an 8% increase in mortality. And the increase in mortality, as we discussed, is proportional and directly to the delay. So you have to take blood cultures, lactate and urine output measurement, and give oxygen, antibiotics, and fluids within the first hour. Now, just the last thing here, focus on oxygen delivery. how do we give oxygen? So the reason we give oxygen, as we discussed earlier in other lectures of circulatory shock, is because if you want to increase your oxygen delivery, you can increase oxygen delivery to your cells simply by increasing the concentration of oxygen that you're giving to your patient. So doing that, you can do that by giving variable methods of oxygen administration, so nasal cannula or a simple face mask. You don't really know how much oxygen the patient is getting because it's variable with the patient's peak inspiratory flow. Alternatively, you can give oxygen via a Venturi mask, where you can change the concentration of oxygen that you want to deliver. Or you can use a normal breathing mask, where you can achieve oxygen of 80%, because the patient is breathing from a bag full of oxygen. So there you have it. So that's the patient basically who ended up in a septic shock secondary to pyelonephritis. So the patient presented at the beginning with an acute abdomen. You have discussed the possible causes. You have taken your basic labs, blood samples, urine samples, and imaging. You came up with a diagnosis and you started your immediate treatment. After that, the patient has deteriorated and ended up in a septic shock, but you're able to understand what was going on there. You followed the protocol of the early warning score chart, and you started to treat according to the sepsis guidelines. Okay, guys, we'll see you now for the next lecture very shortly. Thank you very much, and see you next time.